Oh, you silly thing. That's not right. Zoom and play. You want to turn the lights out?
Today you're assigned to care for a 24-year-old patient who was recently admitted with a chest wall injury caused by a car accident. You having a little bit of Here's the speaker. During your initial assessment, he reports shortness of breath and a sharp pain on the left side of his chest on inspiration. A stat chest x-ray confirms a left-sided pneumothorax. Now you must act quickly and help insert a chest tube to correct the problem and prevent further respiratory compromise.
Mr. Smith, I'm just going to give you a little bit of oxygen.
Your role in chest tube insertion and management is critical because your patient's life depends on your skills. To help you perform the role expertly, this program will show you how chest tubes work inside the body to relieve a pneumothorax or similar condition. You'll also learn how to assist with chest tube insertion and removal, set up and maintain a chest drainage system, monitor for complications, and provide other follow-up care. Chest tubes and closed chest drainage systems are ordered to remove fluid or air from the pleural and mediastinal spaces.
Right here to help you breathe a little.
These devices are used to manage open or closed pneumothorax, or air in the pleural space, pleural effusion, or fluid in the pleural space, empyema, or pus in the pleural space, hemothorax, or blood and air in the pleural space, and recovery from thoracic surgery.
Leave it on.
To understand how chest tubes and drainage systems work, consider the normal anatomy and physiology of the lungs and related thoracic structures. These elastic structures normally expand and contract to allow for respiration. During inspiration, the intercostal muscles contract to expand the chest wall, and the diaphragm contracts and moves down to create negative pressure in the lungs that allows them to fill with air. During expiration, the diaphragm and intercostal muscles relax, which allows the elastic recoil of the lungs to force air out. Two pleural membranes help make lung movement possible: the parietal pleura, which lines the thoracic cavity, and the visceral pleura, which covers the lungs. Pleural fluid lubricates the surfaces of these membranes so they can move against each other smoothly. Negative pressure in the pleural space forms a vacuum which keeps the pleural surfaces together and prevents lung collapse. However, if a pleural membrane is disrupted, the delicate balance can be disturbed. For example, if a fractured rib punctures the parietal pleura, a pneumothorax can occur. In a pneumothorax, air enters the space between the parietal and visceral pleurae, destroys the negative pressure that holds the pleurae together, and prevents normal ventilation. If air continues to enter the pleural space during inspiration and can't escape through the break in the pleura during expiration, a pneumothorax can become a tension pneumothorax. In this life-threatening emergency, pressure in the pleural space increases, further compressing the affected lung. If the pressure builds, it can compress blood vessels and shift the mediastinal contents, including the heart and bronchi. Without treatment, tension pneumothorax can lead to cardiac arrest. Chest tubes and drainage systems help relieve a pneumothorax by restoring the negative pressure in the pleural space, which allows the lung to re-expand.
So, Mr. Smith, we are going to put this chest tube in.
When your patient needs a chest tube, prepare him by explaining the procedure and providing reassurance. making sure that the physician has obtained informed consent, and administering an analgesic or a sedative as prescribed. Also, prepare the equipment, including the closed chest drainage system. To understand how this type of system works, consider its components. A disposable drainage system usually has 3 chambers, each with a different function. The drainage collection chamber collects and measures blood or other fluid that drains from the pleural or mediastinal space. It usually has at least 2 compartments to capture large amounts of drainage. The water seal chamber has a one-way valve to create negative pressure that lets air and fluid escape from the pleural space and prevents air from being pulled into the pleural space. The water level in this chamber reflects conditions in that area. For example, if pressure in the pleural space unexpectedly rises, the fluid level in the water seal chamber will fall. This chamber can also detect air leaks in the system or pleural space. In systems without a water seal chamber, an air leak monitor serves that purpose. The suction control chamber is found on systems that use wet suction. In a wet suction system, this chamber uses water to create the negative pressure needed to remove fluid or air. In contrast, a dry suction system uses a built-in device to regulate the suction amount. Generally, dry suction systems are preferred when high negative pressures are needed. Before chest tube insertion, prepare the drainage system. Fill the water seal chamber to the 2 centimeter mark. For wet suction, also fill the suction control chamber to the prescribed level, such as -20 centimeters of water. With the drainage system assembled, prepare a sterile field for chest tube insertion. For an uncomplicated pneumothorax, expect the physician to use a 14 French or smaller chest tube. To drain thick fluid or remove fluid or air rapidly, expect the physician to use a larger diameter catheter.
Lean over this table.
Help the patient into an appropriate position. If he can tolerate sitting upright, have him lean over a bedside table to accommodate a tube in the 4th or 5th intercostal space, usually lateral to the nipple line. Otherwise, help him into the lateral supine position with the affected side up. In a pneumothorax, air tends to rise high in the thoracic cavity, so the physician will direct the tube anteriorly toward the apex of the lung. In a hemothorax or empyema, gravity causes blood or other fluid to collect in lower areas, so the tube will point posteriorly and toward the base of the lungs.
Mr. Smith, let me see your ID badge.
Before the procedure begins, be sure to follow JCAHO's universal protocol for preventing wrong site, wrong procedure, and wrong person surgery. To do this, mark the surgical site if the physician leaves the patient before starting the procedure, and call a timeout while the patient's awake in order to verify his name, identify the procedure, and confirm the surgical site. Next, assist with the procedure. Expect the physician to apply antiseptic to the insertion site. Then expect her to inject a local anesthetic, such as lidocaine, to numb the area. While the physician inserts the chest tube, reassure the patient and assess his pain level. Administer another dose of analgesic if indicated and prescribed.
Yep, there
That's
we
it,
go.
okay?
After the chest tube is in place, help the physician connect it to the drainage tube on the closed chest drainage system, keeping the connector sterile. As ordered, set up wet suction, dry suction, or gravity drainage. The type used depends on how much air must be removed and how quickly the pneumothorax must be resolved.
Try to relax. Let the chest tube do its work.
If suction is ordered, attach the tubing from the suction control chamber to an external suction source, such as wall suction. For wet suction, increase the suction on the external source to produce gentle, continuous bubbling in the suction control chamber. For dry suction, set the external source to 80 millimeters of mercury, and set the suction control regulator on the chest drain to the prescribed amount. For gravity drainage, leave the suction tubing open to the room air. This lets air escape from the chest drainage system. After the physician sutures the chest tube in place, apply a dressing to the insertion site. If ordered, use petrolatum gauze to create an airtight seal around the tube. Then apply a dressing, such as fenestrated or split gauze and 4x4 occlusive gauze, and tape the entire surface of the dressing. Secure all tube connections with tape or nylon bands to help prevent an air leak. As ordered, arrange for a chest X-ray to confirm tube placement in the patient's pleural space. After chest tube insertion, perform follow-up care. Initially, check your patient's vital signs every hour. Watch for hypotension, tachycardia, and tachypnea, which can signal a tension pneumothorax. In this complication, positive pressure in the pleural space compresses blood vessels and decreases cardiac output, the amount of blood the heart ejects in 1 minute. Low cardiac output causes hypotension. To compensate and raise the blood pressure to normal, the heart beats faster, which results in tachycardia. Also, auscultate your patient's lungs at least once every hour initially. Expect clear breath sounds to extend to the periphery of the lungs, a sign of reinflation. If the lung sounds remain diminished on the affected side, the chest tube may not be resolving the pneumothorax and may need adjustment, replacement, or increased suction.
Good.
Remember to check the patient's oxygen saturation every 2 to 4 hours or as ordered. Report a level that's below 95%, a sign of hypoxemia caused by impaired ventilation. Remind the patient to cough and deep breathe at least every 2 hours. Doing so can help reinflate the lung and ease his breathing.
0 is no pain at all.
Regularly ask him about incision pain and pain with deep breathing, and administer analgesics as prescribed.
Just double check.
Pain is common after chest tube insertion. That's because the procedure disrupts the parietal pleura, which contains pain receptors from the intercostal nerves. When triggered, these receptors send pain signals up the spinal cord to the brain. Check the chest tube dressings frequently to detect blood or other drainage. Change the dressings according to hospital policy. Also, palpate around the insertion site to detect subcutaneous emphysema. This complication occurs when air leaks into subcutaneous tissue and produces crepitation or a crackling sound on palpation.
How are things going here?
Well, actually, doctor, I think there's a little crepitus.
If you detect subcutaneous emphysema, immediately notify the physician, who may reposition the chest tube. To facilitate chest drainage, reposition your patient at least every 2 hours and maintain a high Fowler's or semi-Fowler's position if tolerated. Check the character and volume of the chest drainage once every hour or more often. Near the drainage chamber, mark the date, time, and fluid level according to hospital policy. Notify the physician if chest drainage exceeds 100 milliliters per hour. Excessive drainage can signal hemorrhage, which may require surgery. When the drainage collection chambers are nearly full, replace the system. To do this, prepare the new system and clamp the chest tube. Then quickly disconnect the old system and reconnect the new one. After unclamping the chest tube, make sure the drainage system is working properly. Regularly check the water seal chamber for tidling. The water levels normal rise and fall with respiration. During inhalation, the pressure in the pleural space becomes more negative, raising the water level in the chamber. During exhalation, the pressure level returns to baseline, and so does the water level in the chamber. The absence of titling commonly indicates an obstruction, which can occur when the tubing is kinked, compressed, or clogged, or has a dependent loop. Absence of titling can also occur when the lung is reinflated because the negative pressure in the pleural space is restored. Also look for bubbling in the water seal chamber. Normally, you should expect bubbling immediately after the drainage system is attached to suction, when a small leak occurs in the pleural space, and when the patient coughs or exhales. If you spot unexpected bubbling in the water seal chamber, notify the physician and assess the patient for signs of respiratory distress. Suspect a new air leak, which can occur when air enters the drainage system or the pleural space. To locate an air leak, place a padded clamp on the tubing closest to the insertion site. To avoid raising the pressure in the pleural space, don't clamp the tubing for more than 10 seconds at a time. With the clamp in place, check the water seal chamber for continued bubbling. If the bubbling stops when the clamp is placed near the chest wall, suspect an air leak in the pleural space or the lung. If the bubbling persists, apply the clamp at close intervals, moving along the tubing toward the drainage system. When the bubbling stops, suspect an air leak proximal to the clamp. That's because placing a clamp between the water seal chamber and the air leak blocks the air that causes the bubbling. Depending on the air leak's location and cause, remedy the problem by tightening loose connections or replacing the drainage system. Next, check the suction control chamber. For a patient receiving wet suction, assess the chamber's water level by briefly stopping the suction to halt the bubbling. Then inspect the water level, which should be at the prescribed amount, such as -20 centimeters. If the water has evaporated and its level is low, add enough water to reach the amount ordered. For a patient receiving dry suction, make sure the suction control regulator is set at the prescribed amount. To help determine the effectiveness of the chest tube and drainage system, thoroughly document your assessment findings. For a patient whose pneumothorax is resolving, expect to record normal, easy respirations without dyspnea, symmetrical breath sounds that reach the periphery of the lungs, including both apices and bases, reduced drainage in the collection chamber, little or no titling in the water seal chamber as a sign of lung reinflation, and a chest X-ray that shows resolution of the pneumothorax.
Excuse me, doctor. Mr. Smith is doing pretty well. His respirations have been good. His oxygen saturation has been greater than 95%. Also, he's had no shortness of breath.
When the pneumothorax has resolved, prepare to help the physician remove the chest tube and discontinue the drainage system. To confirm that the patient's ready for chest tube removal, assess for symptoms such as dyspnea and chest pain after the tube has been clamped. Within 2 hours, send the patient for a chest X-ray to verify continued lung reinflation. Then prepare the equipment for chest tube removal. Be sure to include a suture removal kit, 4x4 gauze pads, sterile gloves, petrolatum gauze, surgical tape, and clamps. After providing analgesia or sedation, begin the procedure by clamping the chest tube if this wasn't done earlier. Then remove the dressings from the chest tube insertion site. When the physician is ready to remove the tube, expect her to have the patient perform the Valsalva maneuver and bear down.
1, 2, 3.
This maneuver helps prevent air from rushing into the pleural space when the chest tube is removed. As soon as the physician withdraws the chest tube, cover the insertion site with petrolatum gauze and 4x4 gauze dressings. Secure the dressings with surgical tape and provide other follow-up care. For example, send the patient for a chest x-ray to confirm that the pneumothorax hasn't recurred. Continue to monitor the patient for signs of recurrence of the pneumothorax and evaluate and document his condition. Be sure to ask about chest pain and shortness of breath. Auscultate his breath sounds at least every 4 hours to check for diminished sounds. Monitor his oxygen saturation level to detect hypoxemia. Assess the chest tube site for signs of infection, and monitor chest x-rays for recurrent pneumothorax. As you've just seen, your role in caring for patients with chest tubes is a challenging one that requires expert clinical skills. But you can rise to that challenge every time when you know what to do before, during, and after chest tube insertion.
Hooray for chest tubes. Okay, we can have some lights, please. Stop you. Okay, so are we still recording? Please let us be recording. We don't want that anymore. Yes, it's still recording. Life is good. All right, so we did that. Now let's move on. The physician decides to insert a pleural chest tube under non-emergent conditions. What is your responsibility as Sam's nurse? Do everything that was previously mentioned in the video, right? Well, first of all, is this an invasive procedure? So we need an informed consent. What else? Analgesia, pre-medicate him. This hurts. When they put a chest tube in, it's a stab wound. They make a little slice with a blade and then they stab in using a trocar in between the ribs. It hurts. And you saw if it's a big chunky stuff in there, they need a big tube. So this is a stab wound. It hurts going in. It goes in between the ribs. There's all that nerve running in there. This is not a fun thing. So sedate your patient, or not sedate, medicate your patient. Yeah, don't sedate them. We want them to breathe. What else do we want to talk about? Analgesia. Get the tray. Some physicians have their own specific tray. Your life will be much easier if you know their specific tray. Because if you put out the wrong tray, you'll know that too. They will tell you about that. Set up the system. Get it all, if it's a Pleurovac or the Ocean, Atrium Ocean like this, there's some videos on Canvas from Atrium to view again. Chest tubes, you need to know these things. And the best thing to do is just to listen again and figure it out. Yes, you need to know about titling. Yes, you need to know about air leaks. You need to understand how a chest tube works, okay? Because you're watching them and you need to make sure that they work for the patient. You want to check the pressure, make sure that it's as prescribed, set as prescribed, whether it's to dry suction or wet. And ensure sterile technique is maintained during the procedure. How do you ensure sterile technique is maintained during the procedure when you're not the one doing the procedure? If you're not the one doing it, how do you make sure that it's maintained? Yes, watch it and call it out. So, this is a trick I've always done. You bring 2 sets of gloves, surgeon size gloves, whatever size a physician wears. As soon as you see a breach, you pull those gloves out and say, I have your new gloves here. You need to change those gloves. However you want to say it. That's how you do it, okay? I'm going to get you a new tray. You just tell them. Okay? They're not going to do anything back to you because they know when there's a breach. You know when you make a breach. And you appreciate it if somebody tells you, right? What's that?
I said, and they're there with the solution.
Right.
Gloves.
Here's your new gloves. I'm going to grab another tray. It's not like you're going to order 2 trays up, but it's highly unlikely that they're going to, well, just intervene. If you see a breach, intervene. And then the petroleum or petrolatum, whichever you want to say, gauze dressing. So that's a little Vaseline dressing that we're going to put around the site. Everybody's seen those on the carts, wondered what they were for, and that's what they're for. And then definitely position the drainage below the chest. This is something, have you ever noticed that the chest tube, like the Pleurovac itself, is sometimes taped to an IV pole? And like people are walking around with their chest tubes. Because when that patient goes down to have a chest x-ray, you want to make sure that it's low. Sometimes you'll see them put it on the back of the, now if it's higher than the insertion point, that's not a good idea, is it? So we have solved that by attaching it with zip ties to an IV pole. That's why they're there. Those hanger things, those hangers, you can hang them up like this. I've seen that happen too. Oh, I'm just going to hang this here while I push this. I'm like, oh, no. So make sure that you just educate your transporters to make sure it stays low. And position your patient. Okay, take out a piece of paper. Close your books. Close all your cheat sheets. Let's do a fast true-false kind of thing. What is the height of the column of water in the suction control mechanism? It is the height of the column of water in the suction control, not the setting of the suction control, that actually limits the amount of suction transmitted to the pleural cavity. True or false? Well, just take yourself a little, let's do true or false. Let's do it real quick. We have 10 items. There we go. Let's move that. You go down here. Okay, take yourself quickly. We'll go through these. 2, suction pressure plus 20 is commonly recommended for adults. True or false? Bubbling in the water. Don't say it out loud. Just write it down. Bubbling in the water-sealed chamber means that the air is leaking from the lungs, the tubing, or the insertion site. True or false? The rise and fall of the water level, with the patient's respirations reflect normal pressure changes in the pleural cavity with respirations. True or false? The chamber is a closed system, therefore water cannot evaporate. True or false? To declot drainage tubing, put lotion on your hands, compress the tubing, and vigorously strip along the segments of the tubing before releasing. True or false? You lower the bed on top of the drainage system and break it. Because you noted air leak from Sam's lung during your initial assessment, you may clamp the chest tube for a short time and keep those lovely color schemes. You may clamp the chest tube for a short time it takes to establish a new drainage system. True or false? Chest tube becomes dislodged from the drainage system because you noted air leak during your initial assessment. You can submerge the chest tube 1 to 2 inches below the surface of a 250 ml bottle of sterile saline or water. True or false? Collection chamber is full. You need to connect a new drainage system to the chest tube. It's appropriate to momentarily clamp the chest tube while you disconnect the old system from the new. True or false? Okay, the drainage system falls over, spilling the drainage into other drainage columns. The total amount of drainage can be obtained by adding the amounts of drainage in each column. True or false? All right, so ready to get the answers? Because you're all experts in chest tubes now, right? Okay. True. It is the height of the column of water in the suction control mechanism, not the setting of the suction, that actually limits the amount of suction that's true. That's why we need to keep making sure that it's the correct level. So we add water to it. It's minus 20 centimeters, not plus 20. Minus 20 centimeters. Tricky, tricky. Did everybody get that right or wrong? Bubbling in the water seal chamber means the air is leaking from the lungs. Yes, so if there's bubbling in that water chamber, that's true. The rise and fall with patients' respirations reflect normal pressure changes. That's true. So we want to see that tidling. The chamber is a closed system and therefore water cannot evaporate. That's not true. We have evaporation. That's another reason why we're going to take a close look at that, what that fluid level is. Do we need to add any more to maintain that minus 20 centimeters if it's a wet system? To declot, this is false. We don't do this. However, we used to. We used to strip chest tubes. It's very fun and satisfying to strip chest tubes. Not such a good idea. So what happens is the clots form in those tubings and they can plug up. So then we're not having drainage, right? Because we have big clots. Somebody beeping you? So if there's clots, we would break it up, like, gently break up those clots so they'll move along the system. What we used to do is we put that lotion on that we got from Allen Brothers Mortuary every Christmas, because that's what they give the nurses. Every nurse gets hand lotion, bottle of hand lotion from the mortuary. It says Allen Brothers so that you always refer them to Allen Brothers and Vista forever, right? It's very smart marketing. It is. And Mrs. Allen was also our nursing supervisor on nights, so that's probably why we had it. Okay, so then you lather up with lotion, and you pull along the strip along the tubing, and then you release, because you've created a pressure, right? Okay, so you strip along, and it's collapsed upon itself, and then you release, so it goes, right? So it sucks. That's how stripping a chest tube works. Okay, that makes sense. Okay, I could probably get the junk out of there by doing that. Or I could pull something off, like the increased pressure that you make. Did I write it on there? 400 centimeters of pressure can be generated when you do that. If you have somebody who just had a bypass surgery and you strip their chest tubes, they got chest tubes in and they just had new vessels on there put on, you could pull a vessel off with that kind of pressure. Don't strip. Don't strip. We used to do this, but we've learned that it's not a good thing. Now, if the surgeon comes in and starts to do that, the surgeon is well aware that they have sutured the vessels on, and they know what they're doing. So, the surgeon might come in and strip a tube, but don't you ever do it. I think I've made that impression upon you now, right? With what? If it's clogged up? Then you just mush it up with your fingers. Like, try and break it up, but don't do that. Okay? All right. F7, you lower the bed on top of the drainage system. And because you can't clamp it for an extended period of time, right? So what are you going to do if this happens? Yeah, you could put it in underwater. Yes, you could. Does this ever happen? I've done this myself. You really feel smart when you do something like that. But your friends, yeah, and you ask people to help you. You're part of the team. You always get the team on board. Because, okay. Chest tubes becomes disconnected from the drainage system because the air leak from the lung from your initial assessment, you can submerge it. Okay, so the chest tube's disconnected. If we just leave that tube hanging there, they take a breath in, pull air in. What happens? Well, we could get attention, but we're increasing the pneumothorax, right? So if we put it in underwater, what happens when he sucks in? A little bit of water rises up the tube, and then he blows out, and the air escapes. It's an underwater seal, right? It's fine. It's good while you're screaming at your friend to go get another system for you. You grab that bottle that stays in the room that you've been using to top up the drainage system to make sure that you have minus 20 centimeters, right? You grab that same bottle and stick it right in there. Okay. How's your scores going on this? 100%? True. Number 9 is true. Collection chamber is full and you need to connect a new system. It's okay just to clamp it momentarily. Remember, it says you can clamp up to 10 seconds is what they said in the video. So my rule of thumb is whenever I clamping or suctioning, this is what I do. I'm holding my breath while I'm doing it because when I have to take a breath, so does my patient. Okay? So just whenever you're suctioning a patient, changing the system, hold your breath because then you know what it feels like. Party out here. Okay, number 10, true. The drainage system falls over, spilling all those into all the columns. You just add them up. Doesn't matter if they fell over and all the fluid went into different columns. It's still the same amount, right? Kayla, you're looking at me like it's not.
No, I just, the water to the far left of the chamber system, I just assume that that's mixing with the drainage as well.
No, there's a seal between there. It won't. It's just the collection chamber of the drainage. You know, it just spills over onto each other, and then that's what happens. Okay, so let's get through here. Chest tube is removed 2 days later. He is discharged on one day. On day 3, since being diagnosed with obstructive sleep apnea, he's lost 10 pounds, but there's been little improvement in his symptoms, and he realizes the car accident was because of the sleep apnea, and he wants to discuss further treatments. And what treatments do we use? Well, we have a dental appliance that you put in your mouth, and that actually brings your jaw forward so that you get an underbite, right? So that's one way we can do it. We have the CPAP machine. There is a surgical intervention called a palato. Oh, I have to look at it to say it. I love the word uvulopalato-pharyngoplasty. Okay, but if you break it down, uvula, take out the uvula, palate, pharyngoplasty. So what they do is they go ream out the back of the throat, get all that stuff out, no more uvula in that guy's throat, and make a bigger airway, right? That makes sense. How do you think that feels having that procedure done? Like, well, your tonsils, your uvula, everything's like scraped out of there. I like that word, scraped on out. Soft, that's gotta hurt. Works, is it gonna fix the sleep apnea? 50% of the time there's a success rate. 50. No. 50%. They still do it. Tracheostomy is sort of the last resort. So that's how we're going to fill trach into this whole thing here. See how I did that? Poor guy with sleep apnea. Now he got in a car accident. Now he has to have a trach. Okay, so Sam decided, okay, least invasive, let's go for the CPAP machine. Provider writes a prescription, they find a place to get it, and you help them by giving 3 names of companies, you're a good person, and find out how much they're going to pay for it. So he calls you a couple weeks later and says, I'm dry mucous membranes, I'm getting nosebleeds, my ears are sore, what are you going to do? Humidify. Put the water into the machine to humidify it. That's going to help with the mucous membranes. Cotton behind the ear. Check the mask fits properly, and then saline nasal spray will help and protect his skin. Okay, 6 weeks later, he comes back in. The CPAP has not worked out. This is not working for him. He elects, the physician is going to put in a number 8 Shiley with a disposable inner cannula. Sam becomes increasingly anxious after receiving the news. And how are you going to prepare him for the idea that he's going to have a tracheostomy? Because this might be you're the one that gets to tell him how to do it. Well, so we're going to give him things to look at. Yeah. So what we have here is some pictures of some trachs, and this gentleman here who has his trach on for sleep apnea, and then it's buttoned during the day. He has a button in it when he's not sleeping, so he doesn't have a trach in place at all times. This is an interesting read here. It's this gentleman's experience of having a trach. So it's interesting to read it from the patient's perspective side of it, how he went through that. So I put that up there. Okay, so we're going to use visual aids like you suggested. There will be some body image issues could come from this. I mean, how attractive are you looking with that in place when you roll over and say, hey, baby? There's all that stuff to think about, right? Right? Think about it. Those little dickies? Those little things around his neck? Okay, so stoma protection, which is what these things are. So this is like a little dicky that he puts over the place. Now think of what our upper airway does. It filters, it moistens, it warms the air that we put into our lungs. That's what it's supposed to do. So if you lose all this upper airway stuff and you're breathing through a hole right here, it's not warm, the air is not warmed, it's not filtered, there's no nasal hairs. That's why we have hair in our noses, is to catch all the little dirt and bugs that come along. So, you're breathing through this hole and some mosquito comes, you could suck in a bug, an aphid or something. The mosquito's kind of big. Okay, so you want to protect that stoma. So there's different devices. This is breathable, but there's all sorts of products out there for them. They can make their own even. But you want to protect the stoma. You want to filter and warm. It'll warm the air too. And okay, so are they going to cough like that? Rockets are going to come shooting out of there. Well, if they have a bad cold, it might. So that's another reason to have that covered. Communication, when the trach is in place, unless unless the cuff is down, it's not going to, you can't talk, right? So you're going to have to educate them about communication. So somebody in the hospital getting a trach, we may use a communication board, but prepare them for the communication problem that's to come about. And to educate others. Often what you see is people yelling at patients with trachs. Well, just because they can't talk doesn't mean they're deaf. So educate what's going on. So he undergoes a tracheostomy procedure without complications, and when you return in the morning, you assess the new trach and you note the trach tape looks tight. And you're unable to insert one finger. Is this problematic? Yes. Yeah. So you should always be able to slip one finger in under your trach tape or collar, whatever you're using. And we are going to do, we're going to play with trachs and chest tubes when we have SimLab coming up in a couple weeks. So don't think this is going to be the one and only time you're going to know about it. So if the flange of the trach completely covers and compresses the stoma, you could have a subcutaneous emphysema happen, right? So air could be leaking into that. Yeah. Exactly. So they're going to get thick and thick. Remember they talked about subcutaneous emphysema? What are you going to look for? Crepitus. It feels like bubble wrap when you touch it. It kind of feels like Rice Krispies. You know what Rice Krispies sounds like. It feels like what Rice Krispies sounds like. Do you know what I'm saying? You put milk on Rice Krispies and it goes snap, crackle, and pop and does all that. But that's what it feels like when you're touching it. So your red flags of a trach. If you walk in and you're taking, or your patient's on a monitor, or you're taking their pulse and their trach is just sort of moving the same beat as their pulse, is that cool? No, why? So it's sitting on an artery, right? There's an artery there that's bumping that trach tube, right? It's not the carotid, it's the innominate artery that runs down there, but that was close. I always say that because that's the one I do know. I do know it's the innominate artery. So if it stayed there and continued to pulsate on it, wear down, what happens then? We get a little fistula. Fistula happens on an artery. What are we going to see? A lot of blood. Yeah, a lot of blood will come out. An arterial bleed will happen from the face. So this is not cool. We don't want to, if you see that, not good. Hello, doctor, immediately. I'd call in respiratory too, because your respiratory therapists, they're your best friends when it comes to anything respiratory. These guys know these really well. So have them come in too. We're not going to let the bleeding happen.
Okay.
Yeah, we're not even going to talk about the bleeding. The bleeding is, that's going to be a big show. We don't want that. There's nothing we can do about that. Think about that. Can we do anything about that innominate artery bleeding out? Hey, stick your finger down there through. I mean, there's nothing we can do about it. But it makes an impression upon you anyway. Dislodgement. Less than 72 hours or greater than 72 hours. What are we going to do? What if it dislodges in less than 72 hours? It's going to seal, and we're going to use the upper airway unless we have a laryngectomy, and then that's a whole different story. But we're going to maintain the upper airway and close this one, right? If it's greater than 72 hours, maybe they've had it for 2 weeks, 2 months, 10 years, you just pop that trach back in there. It's good. There's always a trach at the bedside. We're always making sure we have an extra trach at the bedside, same size. So our next action should be when we found this crepitus in the neck. I'm going to be done in just a minute. Call the doctor. If no doctor, we're going to do trach care and retie because we don't want that flange pushing back any longer. Here's what they look like when they have crepitus. Do you see? He has subcutaneous emphysema. Now, he's changed his age again and his ethnicity, but this is still Sam. He now has subcutaneous emphysema. And a couple years ago, we had a patient over at Tri-City. One of the students had subcu, and the poor guy, he's lying in there, he's all puffed up, and he'd like, so he could look at you, he'd open up his eye like that, because he couldn't see us.
Like your eye was gonna pop out. Your eye.
Did you think my eye was going to pop out? Sorry.
It really like. Oh my gosh.
Sorry. No, we had to do that to his eye. My eye looked like it was going to pop out?
You like went very dramatic.
Okay, so you'll remember that. Okay, so these patients, they can't see. They have difficulty talking. They're air in their subcutaneous tissue. They have to open their eyes up like this. Molly? Did it? No. Okay. It's Halloween. So what should you do? There's another, this is actually, see all this subcutaneous emphysema? I don't know, you want to take the light down maybe? Do you see where this is? See all that air? It should, right? Air is white on x-ray, correct?
No, air is black.
Air is black, you're right. But this is all through here. See all this?
Yeah.
Okay. Thank you.
It's okay.
Thank you for correcting me. Thanks. Okay, so it's not expected. Notify the doctor. Explain what's happening to the patient because they're freaked out. And elevate the head of the bed. What else can you do? Not much. It absorbs. Eventually. Oh, we're done. Any questions, comments, criticisms, critiques? All right, so we will come back next week and do asthma and lung cancer. Thank you. COPD or with lung cancer, isn't it? All right. Okay, any questions? Good, everybody's happy? I'm going to be here most of the day if anybody needs to come and see me after. That's it. Thank you. Let me turn this off and hope that everything worked out. Here's my book.